should mention, I've been giving different lengths of this talk, so I'm going to give some background on the AFib stuff, but I might kind of go fast. And so if you have questions about some of the background or sort of substance, let me know, because I really want to focus on the stuff we're actually doing. So as you mentioned, most of my work is government funded. We have kind of dabbled with Google, stipends and things. I'm going to be talking about this app on the bottom, QRhythm, but we have developed some other different digital health applications. I'm kicking off with just the clinical vignette. So this is a 75-year-old woman found to have atrial fibrillation incidentally on an ECG during a routine clinic visit. She had a past medical history of hypertension, pre-diabetes, some sleep apnea. Her heart LVEF was normal. Her atrial size was a little generous. She was referred, as these patients often are, for an external cardioversion. She had AFib right afterwards. We started her on flecainide, which is often what we'll do. That didn't work. She had a PVI 1 month later. She had recurrence 3 months after that, after the blanking period. Had another AFib ablation performed 2 months later with multiple lines and different other ablative strategies. Recurred 2 months after that. Brought her in for another antiarrhythmic medication called dofetilide and tried a cardioversion. Admitted 2 weeks later because she's back in AFib. That didn't work. We started on amiodarone, which is kind of the last line. She's back in clinic 1 month later. She's in sinus, but now she's in severe bradycardia and fatigue. The amiodarone was stopped. She has another ablation 3 months later. Unfortunately, this time she has a hemorrhagic stroke. After all that, she's kind of discharged. The plans are the kind of final line for this, which is an AVJ ablation with a device placement. But she said, I actually feel okay, and my rates are reasonably controlled. And so we just kind of left her alone. So that's one patient. Here's a second patient, a 69-year-old, referred to EP clinic for a second opinion. History of hypertension, diabetes, coronary disease. AFib was diagnosed about 20 years ago. Was initially, he thinks, paroxysmal, but now it's more persistent over the last few years. He thinks at one point he tried flecainide, that was stopped because of fatigue and bradycardia. He's undergone 2 AFib ablations out in the community. It sounds like they had done PVI as well as different types of lines, roof lines, things like that. Something called cafe ablation that we used to do back in the day. On presentation, he's just an AFib. We don't know how long he's even been in it. He says, "Can you just give me one last chance with a third AFib ablation?" He undergoes that, and 5 years later, he has had no recurrence of AFib. He says that, you fixed it. The AFib is gone. So, just as kind of a background, atrial fibrillation is the most common sustained arrhythmia we deal with. These are actually older numbers, but the estimates are expected to even increase in greater numbers now that we have more closer monitoring. About a quarter of people will have it at some point in their lifetime. The costs, again, these are from 2006. I would imagine these are even substantially higher now, run into the multiple billions of dollars. Other than, I think it's important to always, distinguish that the anticoagulation is really the pinnacle of AFib management. So there's really kind of unequivocal benefits of that. So that's not really a big decision. But the decision about whether to try to keep someone out of AFib, something we call a rhythm control strategy, versus letting them stay in AFib and just controlling the rate, has really been the focus of what I'm going to talk about. And as we'll sort of see, there's data going in both directions. So just to kind of summarize our 2 patients, in patient 1, you have someone who's had 3 AFib ablations, 3 antiarrhythmic medications, had a major complication, number of hospitalizations. After all that, basically back where she started, didn't help at all. Second patient, same thing, 3 AFib ablations, has tried multiple antiarrhythmics. In this case, it's like this guy's fixed, like he thinks his AFib is gone. The conclusion of all this is that trying to predict an individual patient who will be successful with this for a rhythm control strategy is pretty hard. And that's the question we sought out to answer is, can we use AI, can we use machine learning to try to predict which patients are more likely to have the better outcome with rhythm control? So I think to kind of answer this question, I think it's worth stepping back and saying, well, when we say something's evidence-based, like what does that actually mean? Which ultimately is, how do we know if a treatment actually works, before we've applied it to patients? Most of us would know there's 2 ways we look at these. There's observational studies where you just look at who's received the treatment, who hasn't. You try to adjust for confounders, and then you try to compare the difference. Obviously that's substandard because you can't always adjust for all the confounders, which leads us to randomized controlled trials. In this case, you have unbiased ascertainment if it's blinded. But again, you have to decide who's eligible, and we'll talk about some of the limitations of these. In terms of like observational studies for this, There's been a number. As you can imagine, each group over the past 50 years of managing AFib has published different things looking at certain groups that are more or less likely to do well with a rhythm control strategy versus a rate control strategy. I'm not going to go into these other than to say that almost everyone, if you go to the paper, didn't adjust for some confounder. There's something that they probably missed that biases their results. So the first question we sought to ask with machine learning is, what if we look at all of the confounders? What if we look at the entire EHR? Can we actually predict, which patients are more likely to have a certain strategy? And so that's what we did initially. So this was a couple of years ago. We looked at the UC Health EHR data from Compass. We got 42,000 patients diagnosed with AFib. What we looked at was what was the initial strategy. So we had the AFib diagnosis, and then what did they get? Did they get a drug or an ablation or nothing over the next 6 months? The predictors we looked at, so we looked at some of these things that had been described previously in the literature, like hypertension, obesity, diabetes, but then we also wanted to look at the entirety of the data. So we looked at 50,000 diagnoses, medications, and procedures that were all available at the time. We used a number of machine learning models. In fact, the big probably strength of this is that we did all of them and then kind of compared which ones were better. What we found is, which is not sort of surprising if you go into the machine learning literature, is that the most complex model actually was the most successful in this case, something called the deep and wide model. The upshot of it is it still wasn't very predictive. Our AUCs were not great, 0.6. We tried to sort of frame this for publication as well. We might be able to head off referrals. If we can predict who's going to have a rhythm control strategy, those might be people that would go to an EP clinic. And as you can see here, there was sort of a nonlinear increase in the inappropriate referrals as you sort of become more lax in your prediction threshold. So it really wasn't very helpful. And there were big issues with sort of looking at this. The first thing was the data itself. Over 90% of the patients had a rate control strategy, which isn't really necessarily at least how it's managed clinically contemporarily. And we also had no idea what those predictors were. We were looking at 50,000 sort of in a vacuum, which is again the nature of machine learning. So we kind of wanted to dive in. This is always what you put in your grants and everything. Well, we're going to do this at a high level, and then we're going to do some chart review. And so we tried to do that. We basically went to the same sort of cohort of patients, and working with Chris Barrett, who's one of our EP fellows, we looked at about 400 charts. This is hard. It's not like you're trying to find some variable in the chart. You actually have to try to go through the course and figure out what happened as long as we have a longitudinal record of each patient. So this took a long time. It clearly wasn't something that was going to scale up to the level of 50,000 patients. But it was important because what we actually found is that we can only confirm the diagnosis is about 3/4 of patients. The other ones, it sort of showed up on their record, and we never, through the rest of the hospital record, were able to record whether they actually were treated for it or anyone ever addressed it. We tried to do some stuff with this information. I think the most useful thing we tried to predict was whether someone was likely to change their strategy. We found that by grouping them into paroxysmal versus persistent, that was sort of an important sort of point to frame the analysis. And ultimately, we found certain strategies did seem to be more likely to have something else needed. This is actually kind of interesting clinically because we found that for people with persistent AFib, over 80% of them, if we just did a cardioversion, just tried to get them out within the first year, we're back needing something else. And so it sort of said that, that's right now, that's the standard of care is you cardiovert all of them and don't do a drug or anything else. And so it sort of said that maybe we should be rethinking that strategy. But other than that, it really didn't reveal a lot about the sort of management pathway. I'll just touch briefly. There's obviously been a number of randomized controlled trials about this. If I was giving this talk about 5 years ago, this would be the one everyone would talk about as the AFFIRM study. This was completed in the early 2000s and basically compared a rate versus rhythm control strategy in which there was no difference found. And so up until about the last couple of years, if you had gone to most general cardiologists, they tell you it doesn't matter. We only do this for symptoms. It's not going to improve mortality. There were a lot of issues with these studies. I mean, the first one being that it didn't include AFib ablation. This was before it was widely accepted. And providers could stop anticoagulation if they thought the rhythm control strategy was working, which turned out to be a bad idea. That wasn't the only study. There were whole numbers, AFFIRM, RACE, Hot Cafe. There were other studies, and then they meta-analyzed them all of these at the same time and showed that there's basically no mortality benefit for a rhythm control strategy in contrast to a rate control. Over the years, I think there's been different studies. Cabana was sort of a famous one that looked at AFib ablation. It did not show a mortality benefit. There is sort of subgroups where it seemed to work. Castelliep is sort of one of the famous ones. So people with heart failure tend to get a mortality benefit with AFib ablation. Depending on who you talk to, there's sort of some issues to that. And follow-up studies to that have been less fruitful. This was really the big study. This was released a couple of years ago. In fact, when this came out, some of my collaborators said, well, I think we're done now because this sort of closed the book on it. We'll talk maybe about that's not the case. This was the East AFNet4. This was a study looking at the first treatment for patients diagnosed within the first year. Again, this is a composite outcome of death, stroke, hospitalization, as well as acute coronary syndrome, which is sort of an interesting one to lump in there because we don't tend to think of AFib related to coronary artery disease. They didn't see a difference in hospitalizations, but they saw this clear, improvement in the primary outcome, and this included stroke, which was kind of a novel thing. The reason that we couldn't, necessarily just take this and say that we're done is this graph on the right, which showed all the different strategies. So they chose a rhythm control strategy, but it could be any number of medications. In fact, the one that was, if you see this at the bottom, this is AFib ablation, was only 8% of these initial strategies. So even though in the AFib ablation community, this was sort of hailed as a huge, success, I think it still left us, it's not entirely clear what the initial strategies should be for these patients. And so I think just stepping back and looking at randomized controlled trials in general, I think the framework we teach our residents and fellows how to interpret these is the PICO, patients, intervention and comparison, and outcome sort of framework. And it's actually, when you look at all the different ways you can sort of iterate a trial, all the different types of patients that you can decide whether to include or exclude, all the different interventions and comparisons, and all the different outcomes. You can see how you start getting into this, how many like randomized control trials are we really going to do? I can start looking at, persistent versus paroxysmal of a certain duration, maybe compare a couple strategies and then look at stroke. But then someone says, well, this one didn't really include lifestyle modifications, or you didn't account for age or symptoms when you're designing this study. And it kind of leads us to this current state of how we apply these evidence randomized controlled trials in practice. You have a trial that shows as type 1 type of patient that's eligible to enroll, and they have treatment A and they have some benefit. But what happens is the person seen in clinic is really kind of more like type 1.5. They're not quite the same. There's maybe some differences between them and the type of patient that was enrolled. The clinician says, well, close enough. They apply the treatment because, that showed that it worked in the clinical trial. But again, this is all in the clinician's mind. We're inferring that difference. And it turns out that 0.5 is meaningful, then you actually may do worse with that treatment. And so, there's issues with sort of the practical application of evidence-based medicine. And so it kind of gets to a couple of questions that we sought to answer. So one is, can we quantify that difference? Can I tell the difference between the patient 1 and 1.5? And then is there a way to learn, or do we need to do all these RCTs? Is there a way to learn from the experience, managing patients who are type 1.5 so that we don't have to do, 40 different RCTs? And this is kind of the crux of what we've been doing. This is kind of and the way I kind of like to explain this is start by thinking, when we make a clinical decision, what are the components? And then I'll sort of show you how this works with a modeling perspective. So the first thing you do when someone comes in to see an expert is you figure out what type of patient is this? What am I, in my mind, I sort of get a picture of the type of patient. Once I sort of have that, I select the treatment strategy based on what I think will work, and then determine the overall effect. And then, we're all humans, we all want to do better. So then if they do better or worse, then I sort of, reframe in my mind, whether that strategy would work for that type of patient. Again, there's problems with doing this in your mind. It's subjective. Most of us overweight, last experience or anecdotes. And of course, some of us have, in a lot of cases, you have other, motivations that may have nothing to do with that patient, such as like RVUs or referral concerns. So what we sort of said is, well, you can model this. And in fact, there's a framework for this. It's called reinforcement learning, in which case you sort of define each of these states. So the type of patient, determining that type, we call that determining the state. And I'll show you in a minute what that means. The treatment, we call that the action. And then the outcome, or what we're really trying to optimize, is called the reward. And the algorithms that we use, which are kind of grouped under this category of reinforcement learning, are ways to take that. So you observe people being managed sort of in the wild, and then we learn from the data, and we figure out for which actions and states do people expect to get the highest reward. And that's sort of the optimization goal. And so, I won't go into a lot of detail. Again, this is, we could talk for hours about how, all the different types of algorithms. The basic idea, though, and the reason that this is powerful is that if I'm in state, let's say I'm in state, time t, and I have two possible strategies, If I follow one of those, my sort of state changes, and now I have a whole different set of strategies that might be available. Each of those may carry a different reward with them. And there's actually different ways that we can evaluate this. What we're trying to optimize is something called the Q value, which is basically what's the expected reward for a given state and a given action. And there's an equation we use for this called the Bellman equation. And I wouldn't go, you don't have to go into too much other than there's really two parts that are important. The first is this part, which is that when we're trying to decide which of these three actions here to choose, and I'm at this state, I should account for all of these future actions and potential rewards down the road. And that's what this figures out. And there's different ways to kind of calculate this. We call it the expected, long-term return. And the second part is that this is trainable. So this is, we can start with kind of a set of estimates, collect the data, and then update those as we collect new data. And so it's important because these are a learning framework. You don't have to be perfect. The model doesn't have to be perfect right out of the box. And so to go into just a little bit on how do we define this state, again, this is not necessarily, you're trying to reproduce with data what the human brain does already. But it is kind of, this is the way I was taught to manage heart failure patients. This is Edmund Sonnenbluth back at Albert Einstein said, create a model of the patient and then treat the model. Well, if you think about when someone comes into clinic, you kind of do that already. You might have is it a frail old woman? This is kind of, we call this a two-dimensional representation, but it's you form this latent space in your head about what type of patient am I dealing with. And what's interesting about that is you actually end up treating that kind of latent space. So if these are the only two pieces of information and it's a vigorous young woman and she's asking, am I at risk of cardiovascular disease? They're like, no, that's more in the frail old man space. So again, you don't have to do this with far more than just two variables. We can do this with age, weight, blood pressure, anything you can measure. And what's interesting is once you kind of create that space, you can start to form groups in that, different clusters, people who are older with high blood pressure, young normal weight patients. Again, the type of patient, when we say what type of patient is, translate that into what's the location in this latent space. So of course the question is, well, how do you, once you get there, then you can treat people differently, you can determine different probabilities of disease, but you have to get to this point, and how do you get there with data? And that was sort of the question that we sought to answer. And again, I just sort of put this at the bottom because again, we're basically just trying to do with data what a human expert does. A human figures out what type of patient, we're trying to map out a location in latent space. I won't just, someone we can talk later, people ask, well, what about risk scores? Same idea, except keep in mind, the first thing that we teach medical students is when someone comes in, assess, are they sick or not sick? That's actually a latent, calculation that you're making from thousands of variables. Every, pixel that's generated on your optical cortex goes into that. So your brain is making these advanced calculations. It turns out if you want to do this with data, you need complex algorithms. Your brain is extremely complex algorithm, it turns out. So we wanted to do this with AFib patients, kind of coming back to where we were. So we went back to that data set, of 50,000 AFib patients, and then looked at all these diagnoses and treatment. And we said, what happens if we try to create a latent space representation from those? And we did that using sort of a combined effort of methods, something called a variational autoencoders followed by clustering. And then importantly, we wanted to know what was behind those. So we used an explainable model, something called the SHAP algorithm. It's sort of, industry standard for these things. And importantly, I just highlight on the right side here, every time we predicted a model, we tested on some other data that hadn't seen that. And so it's multiple splits of the data, which, is how you get from 50,000 down to testing sets that are more like 2,000. Again, this is, we could talk, in the field of machine learning, this is the hot topic of sort of creating these latent spaces and determining distances. A variational autoencoder is kind of two neural networks, that oppose each other. There's an encoder network that tries to create this continuous 13-dimensional, in our case, latent space, and then a decoder that tries to turn it back, bring that latent space back up to the original inputs. The way you train these is the reconstruction error, so you see how well it reproduces the data. We then took that latent space and clustered the data. There's actually a number of clusters, and we actually did it across 2 through 10 using some different methods to compare those. And then once we found the optimal number of clusters, we applied the SHAP algorithm. Again, I won't go into it just for the sake of time. It's based on game theory. These are called explainable models. So it's actually a model you train in parallel to the predictive model. And ultimately, what you get is an output sort of like this. So this is for 2 clusters, and it shows you which diagnoses or which inputs are the most important for predicting those different clusters. And what was neat was when we applied this to our AFib patients, we saw that it actually reproduced different sort of clinical phenotypes that match a lot of what I would, as an expert, think would be patients who might respond differently to treatments. We had lone AFib patients, we had patients who had non-ischemic heart failure. And this was a completely data-driven approach, but yet it seemed to recapitulate what we were looking at clinically. And so, coming back to our sort of framework, we have our states, so we can create these 8 clusters. Now we want to know, can we predict which action is optimal? And this is sort of the second part of this. So, this is sort of what we call tabular Q learning, where we basically assign our patients to a group. This is that sort of step 1 of assigning a cluster. And then for each of those, there's multiple actions that they could choose. And we want to choose the one that has the highest Q value, which is what reward would they get if they select that value. The neat thing again is these are trainable. So even if I say what the model predicts, I can then observe what people actually do, and then can update those values. So the model's constantly learning over time as it's exposed to data. I won't go into the reward shaping and how we determined it. The upshot is we were looking at kind of a composite of death, time to event, and treatment changes. The time to event being the thing we're trying to optimize. We want people to be whatever strategy we chose. We wanted them to be on that for the longest period of time. And again, it was pretty neat when we actually applied this to our data and looked by cluster. Again, the big things that I would say I have to highlight. Number 1 is that this is this third column here. So I've highlighted in bold basically the Q value or the predicted Q value, and you generally want this to be the highest. These are all negative because there's a negative outcome. What's neat is that for almost none of these clusters was none or rate strategy, the one that was selected, which is important because when we looked at just the supervised models earlier, we saw that was the main outcome that people were choosing. So that was interesting. I think the other neat ones was that, for patients where we think that the data and clinical experience suggests that certain strategies might be better, such as lone AFib patients or patients with non-ischemic heart failure, the model suggested that ablation was the best strategy. And also for some of these, you could see that some of the values were kind of close. So it sort of told you that, well, it sort of suggests this value, but that might switch over to a different one because these are pretty close. And as a clinician applying this, you could use that information if someone had preference for one strategy over another. We tested this again on a separate held out set, and it worked pretty well, actually. Sort of surprising that they were actually, if a provider applied a treatment strategy that was concordant with what our table suggested, they had fewer deaths, their overall reward was greater, the time on treatment was greater. But again, the model has to learn. As I said, we train it, that's called initializing the model, but ultimately it has to learn from experience. We showed this, and this was in our submission, that basically we could take a whole separate set of patients and then see if those treatment strategies change over time. We did see this. A couple of them changed to ablation, which was very popular in the EP section, to hypertension in patients with coronary disease. But ultimately, what we really figured out from all this is that you have to be able to deliver this at the point of care, and we're not really doing reinforcement learning because the model isn't what we're using to decide things. We're just sort of mapping people to that. And so to do that, we created an application. This is called the Q-Rhythm application. It's sort of a 2-part one. In this case, for safety reasons, we're just trying to predict initially what an expert would do. So we take the data, we train it by what people are using, and then later we can turn on the second stage of reinforcement learning, where we predict, as rewards come back, we can actually see which one was most likely to lead to the best outcomes. We tested this, just kind of the user interface of about 33 providers here. Not surprisingly, a lot of them were mostly concerned about the safety, but understanding the algorithm was important for them. We're planning to develop this in the same way you would a medication. So right now we're sort of phase 1. We're trying to internally develop the app, but ultimately we're going to start comparing this to actual decisions and ultimately to standard of care and trials. A lot of considerations in this process. Calibration, interpretability, things I didn't really have time to go into today. So ultimately, just to summarize, machines, technology, these have potential to make clinical care much more efficient and much more efficacious. Directing technology, I think, to specific decisions is where the money is. I think an omnibus prediction model that's not tied to any type of clinical decision isn't particularly useful, even though that's a lot of what we're seeing right now. Rhythm management of AFib is a very complex decision that I think is perfectly tailored for this. There's going to be a lot that goes into getting trust in these algorithms beyond just can we accurately predict what we want. I think clinicians are needed in this process. I sort of, in a longer talk, sort of frame this as right now, this is where we're at. You have an IT expert develops a technology and then hands it over to the clinician and says, figure out what you can do with this. I think if we're, as clinicians, involved and our patients involved in the process of developing these, we're more likely to develop meaningful technology solutions. With that, I'll just stop. I'd like to thank our team. These are our developers, Alicia, who's been absolutely amazing before she moved her prior role as well as lately. And then, of course, our EP section has been outstanding.
That's great. We have maybe 5 minutes for questions in the room. Go ahead, Sean.
So it would seem to me that a biomarker would be really nicely integrated within your algorithm here. Status of that, either a biomarker or genetics, maybe,
Sure.
of the patient.
Yeah, I mean, I was trying to present this as a framework, but the reason this is so, I think, so valuable, and this is so, why this is where I think things are to go, is that you can adapt to. There's 2 innovations that this will adapt to. One is new predictors. So biomarkers, it again, ultimately a biomarker, you're still mapping that to some place in latent space. Like BNP, we map to heart failure exacerbation. So having that kind of latent space gives you sort of a reference, I think of it as like the reference genome. It gives this kind of reference representation that as we have novel, better ways to kind of describe people, we'll be able to map them probably more precisely in that space. The other space that's nice is on the action side. So if there's a new treatment that comes out, we don't have to go back and we can just start treating people and see if they do better, using that framework. And so it's very dynamic. I think it's the real draw.
So thanks, Mike. Nice to see the home team.
Yeah.
I have a comment and a question. The comment is just to congratulate you. Your work reflects my biases about large randomized clinical trials, which is that we often look at 5 diseases and think we're looking at 1. And the assumption that somebody who's overweight and has AFib has the same disease as somebody who has mitral stenosis and has AFib is a mistaken assumption. So I'm really glad to see you do clinical phenotyping to begin the conversation. So congratulations on that. The second question, and it sort of speaks to what Sean addressed, is there's a lot of literature lately on characteristics of the surface EKG and whether characteristics of the surface EKG can predict AFib. And you didn't include that in your thinking. So I'm just curious your thoughts about that.
Yeah. So there's 2 reasons for that. One is nobody's actually tied that to a decision, other than maybe we might screen these people more, what's interesting and why I was saying that, so we're involved in projects with Carnegie Mellon trying to do the same, I think everyone right now, because it's the EKG is this kind of hot topic. What's interesting is if you talk to the people in data science, they're all trying to they're basically doing latent space representation of an ECG. And in fact, the models they're using, it turns out that, latent space actually can be a very complicated thing when you talk about manifold learning and how do you measure distance within that space. And that's actually a lot of what they're interested in. And so, yeah, it all kind of comes together with that. But I also think right now, I also kind of think there's a lot of hype with a lot of, because again, all you're really doing is see if we can reproduce what a human does. Only it's actually maybe 90% as effective. Well, is that 90? You can trust 90%, or you want the extra 10 if you've got the arrhythmia? So yeah, I think it all kind of it can all come together. But I think that that one in particular maybe to avoid. In the Grand Rounds version, I go through all the hype of machine learning. So we didn't get into that today.
Mike, great talk. I couldn't help by thinking about the association between what you were showing and what we are now thinking about single nuclei RNA sequencing, the clusters and all that. The one thing that's happening in that space is that the more rates we add, the more clusters we have and subclusters also. So within one cluster, we have now these multiple subclusters that are technically the same cell, but actually, just different with terms of gene expression. You started with 400 patients, I think, right?
It was 50,000 patients. But
no, but
for the clustering, I think was 36,000 was how we trained those.
Okay. I thought the work that you were doing with CRISPR was like.
Oh, that was a chart review. It was 400. Yeah. That was when we learned that this is not going to cut it.
Okay. So I was wondering, the more that and I think it's what Peter was asking, and adding more of these variables into the mix, are you going to end up with more clusters, subclusters? Do you think that at some point you're going to be able to really determine who is going to benefit from one?
Yeah. I mean, so to the point about the sort of the topology of the latent space. I mean, the first thing I should say is I was really excited about this because I've done a lot of kind of latent space representation for other, groups, and it never looks like anything, and it's not useful at all. So this is kind of the first time where this, in fact, Farnoosh, who I work with on the downtown campus, has tried this with COPD patients, and it didn't seem to be any meaningful representation, which is sort of a problem. In fact, this is a problem for the EKG stuff because the models themselves aren't necessarily learning the same space that you have in your brain, which is physiology. And so, what the data divides people is going to be probably highly different from what your brain, as someone who understands systems biology, would. Again, the latent space is a continuous space of different kind of dimensions, different proportions. And so, again, clustering is kind of an artificial, thing that we're putting on top of that, but you don't need to cluster at all. In fact, if you have some equation that can pinpoint your position in latent space, you can just use that. You don't have to have the different groups. And in fact, that's probably, if you look at actually what people do with pictures of variational autoencoders, that's what they do. I don't know if you've seen the ones where they can slowly add sunglasses to, an image. They're just moving, across a continuous latent space that's along the axis of sunglasses, and that's sort of how it works. So it's the same with those types of things. I think that the cellular biology gets a little tricky because I think that there are some probably systems where it's binary, but it's the representation is continuous, and so then it's you can always recategorize it, I guess, or divide it up.
I think you were at time. It was great. Thank you very much.